Thank you everyone who's starting to join us. We're just going to leave it another couple of minutes just to let everyone log in and before we get started. Okay, everyone, in the interest of time and sticking with our 30 minutes that we've got for the webinar, we'll get started. It is being recorded, so if anyone that does miss it or joins late, we'll have the recording ready for people after we've finished. So we've got Tracy Underwood presenting a look at upright radiotherapy research so far, and a little introduction to Tracy. So Tracy originally trained in physics before moving into medical physics research, and over the years she's worked in protons and photon radiotherapy centres across the UK, France, and in the USA, which has given her a broad perspective on different techniques and clinical approaches. For the past 4 years, she's been part of the Leo Cancer Care team as the head of translational research, where her research has been focused on upright radiotherapy. Tracy has been a leading name in modern upright radiotherapy research, and we are so glad that she's able to share some of that research with you today. So we've got 30 minutes for the webinar, so we're going to be sticking to the time as best we can. So we won't have time for questions, but if you have any, pop them in the chat and we'll be able to contact you afterwards directly answering those questions. And Tracy won't be able to see those questions during the webinar, so we will get to them and message you back directly. So I'm going to hand over to Tracy now to get started.
Thanks so much for the introduction, Kate. I'm really pleased to be here with you all today. You might have noticed this picture of the Lego version of our Leo chair. There's a lot of Lego in my house at the moment because my son is a huge fan. And I often think of upright research in the same way. We're gradually building evidence and understanding one block at a time. And today I'm hoping to share how some of those pieces are coming together from different research groups all over the world. Before we go further, I'd like to explain what we mean by upright radiotherapy and how it compares with the standard approach. So on the left here, we've got the conventional gantry paradigm where the patient lies flat and the beam is rotated around the patient. Photon gantries can weigh up to 6 tons, but for proton and carbon ion therapy, the gantries are far heavier and more complex. This video shows the carbon ion therapy gantry in Heidelberg rotating, and this piece of equipment weighs around 600 tons, so it's heavier than a fully loaded jumbo jet. And in contrast, on the right, we've got the upright treatment paradigm, where the beam is fixed and a seated patient slowly rotates. This can dramatically simplify all of our equipment, especially for protons and ions. And the paradigm should bring about reductions in room size and room cost, including for conventional treatments using photons. I'm sure many of us can relate to this cartoon. On the left, we've got the rocket ship, complex and ambitious, versus on the right, the bicycle, simple, yet often fit for purpose. And to me, this raises a question in radiotherapy, particularly for carbon ion gantries. Have we been chasing rocket ships? And with the advent of upright CT, we can now ask whether upright systems offer a simpler, smaller, more robust, and more accessible alternative for radiotherapy, perhaps a better fit for our clinical needs. So far, we've talked about technology, but it's also incredibly important to ask, what about the needs of patients? And this is a really recent report from the Lancet Oncology Commission entitled The Human Crisis in Cancer Care. This highlights that the crisis is not just a medical one, but also a relational one. It's shaped by fragmented systems and the absence of human connection, psychological safety, and relational care. And it's a really important reminder that as we try to innovate, we should also try to improve the human experience. And this is something that's incredibly important to us at Leo Cancer Care. Anytime we try to develop a new piece of equipment, so in this case, prototypes for arms up supports for thoracic treatments, we work with people with lived experience of radiotherapy, and they act as partners in our design process, something we're incredibly grateful for. What are we going to discuss today? Well, it's a really exciting time for upright radiotherapy research, and the knowledge base is growing quickly with new data emerging all the time. Of course, we can't cover everything in 30 minutes, but we'll take a whistle-stop tour through these body regions: head and neck, thorax and abdomen, and pelvis. And by the end, I hope you'll have a sense of where the evidence is strong, where questions remain, and why interest in upright radiotherapy is increasing. Starting with head and neck, we know anecdotally that people with head and neck cancers often struggle to lie down, and this can be due to swallowing difficulties, issues with thick oral secretions, and sometimes with nausea. Our research collaborators at Sheffield Hallam University, Kath Hoban and Rob Appleyard, they ran online focus groups, initially with 13 former patients who'd had conventional treatment lying down, and then they validated the themes they identified with a second cohort of 9 patients. The results are really striking. So first of all, 7 of the 9 patients in the validation cohort agreed that the procedure felt like torture and was traumatic. 7 of 9 agreed that lying down was difficult due to breathing and/or swallowing difficulties. 2 said that lying down was harder than wearing the radiotherapy mask, and 8 of the 9 said they would have been more comfortable upright. This work also agrees with findings from a separate cohort of 11 former patients, where 91% said they would have preferred upright positioning. So this data is really emphasizing to us that upright patient positioning can make a very meaningful difference to this group of people who require radiotherapy. In Russia, clinical teams have treated upright head and neck patients with protons for quite a few years now, giving us real-world experience. Their setup times have been reported to be really fast, so an average in-room time of around 10 minutes, which is very competitive for proton therapy. And on the right here, we've got residual setup errors in the cranial caudal direction. And these are typically within 1 to 2 millimeters. Again, a good finding in the context of modern radiotherapy. And this group have also published promising clinical results for esthesioneuroblastoma. At Hadassah Medical Center in Israel, a recent publication reported on treatments for 10 patients requiring proton therapy for head and neck cancer upright. And their initial setup accuracy in the top row of histograms here was typically within 5 millimeters, I think in line with what we'd expect for conventional radiotherapy. But then after image guidance, the residual setup errors basically reached stereotactic levels of precision. They were around 1 millimeter and 1 degree. In the bottom row of histograms, some sagging after the treatment was noticed when CT scans were taken after the treatments had finished for some of the patients. But this was reported as an area for further study, and it possibly stemmed from the patients relaxing after all the beams had been terminated. the team from the Shanghai Proton and Heavy Ion Center in China have published this really nice comparative data for 28 patients. These patients received carbonine therapy both upright and supine, and by combining these two postures, the team were able to deliver more different beam angles to improve the quality of the treatment. And the findings from this group also allowed direct comparison of positioning accuracy. So on this slide, we're showing residual setup errors for the mandible, which is highlighted with the red box on the X-rays. And in the box plot data, the blue box plots are for the supine residual errors, the red for upright. And in this particular case, for the mandible, the upright residual setup errors were actually smaller than the supine ones. And overall, the study team reported that 78% of fractions were within the 1 millimeter, 1 degree threshold upright, and 94% were within a 2 millimeter, 2 degree accuracy threshold. And these were comparable percentages to those observed for supine positioning. So taken together, the patient experience data, the clinical practice in Russia, the clinical practice in Israel, and here in Shanghai, all show that head and neck cancer should remain a priority for further upright treatments and further upright research. We'll now move to the thorax and the abdomen, starting with the breast. Our fantastic Sheffield Hallam University colleagues, this time Janet Ullman, Heidi Probst, and live drawing artist Sarah Smith, they studied the lived experience of conventional breast radiotherapy, and they found that many women described vulnerability and discomfort. For example, you feel so vulnerable and exposed because you're obviously naked. The whole top half is naked, and there's 2-3 people, maneuvering you, to get you in the right position with the tattoos. Others reported excruciating pain holding their treatment position, pain after surgery, and difficulties lying down. And all of these accounts together highlight the physical and the psychological demands of conventional radiotherapy for breast cancer. When the Sheffield Hallam research team asked this cohort of people which treatment position they'd prefer, not all women preferred the idea of upright positioning. Preferences do vary, but the majority did. And most in that Sheffield Hallam study felt more comfortable and less vulnerable when positioned upright. And in a similar French cohort of 9 women with lived experience of breast radiotherapy, 78% reported that they preferred upright positioning. So while it wouldn't be everyone's preference, there is this majority view that upright positioning would be more comfortable and more empowering for breast radiotherapy. Upright treatments of the breast are not yet mainstream, but we've been exploring various immobilization aspects, and together with Professor Heidi Probst and Dr. Elizabeth Chabner, we've studied the use of bras during upright positioning, the idea being to lift the breast away from the abdomen, reducing skin folds and minimizing skin toxicity. And we found that even for very large breasted women, bras are very effective at providing lift, eliminating skin folds, and also reducing feelings of vulnerability. Dr. Gordon Sands on our team has also been assessing photon beam access, and he's taken surface scans of healthy volunteers, converted them into DICOM format, and asked the question, is adequate photon beam coverage of the breast target possible without any beam paths clipping the contralateral breast or the arm? And he found sufficient beam access for 14 of 15 women in the arms up position and 10 of 15 women in the arms down treatment position. So his work there is really indicating that upright photon breast treatments should be feasible in terms of beam access, really promising finding. And on this slide are some early images from an upright and supine MRI study that we're conducting with Professor Penny Gowland's team in Nottingham. And we're hoping that this data will help us to understand how the breasts move relative to the heart, upright versus supine, with and without a bra, and with different arm positions also. We're really excited to process and analyse this data and hopefully gain some insights into the likely clinical treatment quality of upright radiotherapy of the breast. We'll now move on to lung anatomy and physiology. The most comprehensive upright CT dataset anywhere in the world is held by Keio University and the team of Professor Jinzaki. They have scanned hundreds of volunteers upright and supine using a CT scanner they developed with Canon. And in the study we're showing on this slide from Yamada et al., they reported lung volumes in 100 volunteers. There were variations between different lobes in the lung and person to person, but on average, the lung volumes were around 10% greater upright. And it's easy to imagine that this finding could improve tumor targeting within lung radiotherapy. Following on from this, Anthony Crisciolo, one of our students who recently finished his PhD in the UK, he measured FEV1 over VC in upright and supine radiotherapy positions. And this is a key diagnostic measure in spirometry. Higher FEV1 over VC values indicate less airway obstruction. So his findings showed that airways were less obstructed when people were positioned in an upright radiotherapy position than the supine alternative, meaning that breathing was easier. And this could, of course, potentially be important for people with existing respiratory conditions or with lung tumours. Anthony also showed that deep inspiration breath hold, that's a technique commonly used for supine radiotherapy, was feasible upright, and it had comparable stability upright versus supine. Another PhD student, this time based at UCL, Timothy Lowe, he has analysed upright and supine lung cine MR data for 10 participants, and he's automated tracking of the diaphragm and internal vessels using principal component analysis. And for only one of his 10 participants, the first one with the number highlighted in blue there, was the mean diaphragm motion larger upright. In most cases, the diaphragm motion was reduced upright compared to supine. And similarly, when he looked at tracking an internal blood vessel within the lung, 3 of 10 participants had smaller vessel motion when they were supine, but most had smaller vessel motion upright, and statistically that was significant also. Moreover, the breath-to-breath variability was lower upright for all but one participant, suggesting more consistent motion for the internal vessel upright versus supine. This work from UCL is quite consistent with a recently published 4D CT study of 13 volunteers from Japan. Here, 2 of the 13 participants had slightly less liver motion supine, but for the vast majority, liver motion was reduced upright. This data is from that same study. The first 4 box plots on the left are for the liver, and then the final box plots on the right are for the diaphragm and the abdominal surface. And they show reduced diaphragm motion upright as well as reduced liver motion. But interestingly, they show a small increase in abdominal surface motion. And of course, this highlights that the body is not a rigid structure. There can be quite complex interplays between these different effects, and we may see increases in the motion of certain structures with respiration. On another physiological note, before treatment, most people spend their day upright. They wake up, get dressed, eat breakfast, travel to the hospital, and only then do they lie down for their treatment. And logically, some anatomical settling might occur under gravity when the person lies down. If we think about the liver, for instance, that weighs 1.5 kilograms on average, and it's easy to imagine that that organ might take some time to settle. Indeed, a 4D MRI study from the team at PSI that showed that after lying down, the liver continued to shift for up to 35 minutes, with greater than 5 millimeter systematic deviations for 7 of the 12 participants who were studied after 20 minutes. So as people lie down, the position of their organs, of course, changes under gravity, and potentially keeping people upright for their treatment might lead to less intrafraction motion in this way. But of course, much more research is needed on this topic. Returning to our content slide, our final area of the body to look at is the pelvis. And again, we'll start with the patient voice. This work was performed by Rob Appleyard and Kath Hoban at Sheffield Hallam, and they conducted 3 in-person focus groups which involved 11 men who'd experienced conventional radiotherapy for prostate cancer. And themes identified by these men included fear, particularly around bladder filling protocols and worrying that they could sustain the full bladder. Other themes were discomfort and embarrassment and physical difficulty getting on and off the treatment couch. For this cohort, preferences were more variable, and 18% of the men actually said that they'd prefer a supine treatment because they welcomed the idea of lying down and being able to relax a little bit. But 55% roughly said they preferred upright, and 27% weren't sure. However, the vast majority felt that upright would increase their social connection with the radiographers, and it would make it getting in and out of the treatment position easier. Our next study is from Sophie Boisbouvier and her team at Centre Léon Bérard, who studied 8 men and 8 women who received conventional radiotherapy in the pelvic region. And her key findings: 87% of participants found the upright position comfortable, compared to 73% supine, although this was not statistically significant, the difference here. Interfractional reproducibility was around 1 millimeter. Intrafraction motion over a 20-minute time period was less than 3 millimeters for 90% of the patients. And in terms of setup time, repeat setups took an average of 2.9 minutes when they were performed by a team of 2 radiation therapists. This is a really nice study from Sophie, indicating that upright pelvic positioning is both well tolerated by patients and accurate. The next study was led by Nick Schroeder from Leo Cancer Care, and he scanned 16 men using MRI, upright and supine. And he found that upright, the organs showed more pelvic stability, and in particular, regardless of the level of bladder filling, the prostate remained in the same position upright. We're also conducting some further work on this data set together with some collaborators in Portugal and at UCL. And that data is showing an increased separation between the prostate and the bladder upright, and the same thing, an increased separation between the prostate and the penile bulb, which are promising findings, but require some further dosimetric investigation also to look at the clinical impact. Using the same MRI dataset, Dr. Gordon Sands from Leo Cancer Care worked with mVision to test their AI-based auto-segmentation model on this upright data. And despite this model only being trained on supine MRI data, 80% of the contours it returned on the upright data were acceptable or needed only minor edits. So this suggests that AI tools for supine radiotherapy may already transfer pretty well to upright workflows. The final pelvic study we'll look at today is from Kohei Aguma et al. In Japan, and they created upright and supine VMAT plans for 51 volunteers. These were CT-based plans. And their dosimetric data is shown in these dose volume histogram plots on the right, where the data for the upright treatment plans is in orange and the supine treatment plans is in blue. And we see very little difference in terms of the dosimetry between upright and supine. So their conclusion was upright radiation therapy for prostate cancer is feasible with a dose distribution comparable to that of conventional supine radiotherapy, despite significant anatomic changes. Before closing, I wanted to pull together a few overarching messages from everything we've seen today. So first of all, upright radiotherapy has the potential to be technologically simpler, cheaper, and more robust compared to systems that rely on gantries. Secondly, it's grounded in quite clear physiological advantages. People generally find it easier to swallow and breathe when upright, and across several studies we see reduced respiratory motion of the diaphragm, liver, and lungs, and potentially less gravitational drift amongst the abdominal organs also. Third, the patient voice consistently reminds us why all of this work matters. And across head and neck, breast, and pelvic lived experience studies, many patients describe feeling more comfortable, less vulnerable, and more connected with staff when they're positioned upright compared to when they're lying down. And finally, the evidence base for upright radiotherapy is expanding rapidly across multiple anatomic regions, different imaging methods, and across research teams from all around the world. So taken together, these findings to me suggest that upright radiotherapy is an area with huge potential. Of course, looking ahead, there's so much that still needs to be explored, and this will require collaboration. And one hugely exciting development is Uplift, a new doctoral training network which is involving 19 PhD students across Europe, all with their projects dedicated to upright radiotherapy. And they're due to meet in person for the first time next week, which is just fantastic. We also now have the Upright Radiotherapy Research Consortium, which is designed to be a global community focused on research related to upright radiotherapy. Membership is completely free and open to researchers, clinicians, physicists, RTTs, students, whoever wants to join. Please have a look at our website, consider joining our mailing list, and note that we'll be meeting in person before ESTRO 2026, where you'd be really welcome. Thank you so much for your attention, and thanks especially to all those with lived experience of radiotherapy who contributed to this research. You really do inspire us to do better. Thank you.
Thank you, Tracy, for that fantastic webinar and collecting all that research for us and explaining it so well. So thank you for that. And thank you for everyone that attended. And we've had lots of really great questions coming on the chat. So we'll respond to each of those individually, those that have sent it in. And if you have any further questions, do reach out to us and ask any questions that you have. But that concludes our webinar, and have a good rest of the day, everyone.